Prashant David from the Piedmont New Heart Center.
How are you? Can you hear us okay?
Yes.
So Dave, let me just start by the numbers for you, 3-1. And 3-1 references three Dukies, Prashant, Sunil, and I, against the Carolina fan who just cheered for the Tar Heels. So we got to set the record straight here. Thank you very much for having us.
Tonight.
Now, welcome to Atlanta. Welcome to Piedmont Heart Institute. It's our privilege to be part of the program, along with my colleague Prashant Kaul and good friend. And let us perhaps begin with a slide presentation of our case, and we'll make perhaps some more comments and introductions. So if we can go to the next slide, please. We're in an era, of course, of a global pandemic, of unpredictable patient complexity, unpredictable healthcare provision, and we couldn't be successful here at Piedmont Heart without the many people who are the foundation for our cardiac cath lab. And I just briefly want to recognize those who are the foundation of our program, who have taken time from their personal lives to be a part of this program with us. We've got Deborah, whose daughter is celebrating her 31st birthday today, and she's with us today. Santasha, Dwayne, who's next to Prashant as well, Deborah, Rodney, Michael Shivers, and his team for audiovisual. So we're very grateful for this crew for making this effort out of their personal time and commitment. Let us begin then with a case presentation too. Our case today, we thought, given our timeline here, we'd show you something a little bit different than a hemodynamically assisted case or perhaps a CTO, but instead a very complex case nevertheless of a 64-year-old female whose medical history began with Hodgkin's lymphoma, for which she had successful therapy with both chemotherapy but also mantle radiation in 1982. And as a consequence of that chest radiation, she had deteriorating aortic valve disease as well as aortic aneurysm that led to a Bentall procedure with a bioprosthetic AVR in 2011. The coronaries, importantly, were re-implanted at that time. And over that time period, 6 years later, she subsequently developed angina symptoms, underwent cardiac catheterization at another institution here in Georgia, was identified with ostial right coronary artery disease, for which she underwent percutaneous revascularization with a drug-eluting stent. She has a history, too, of hyperlipidemia and hypertension, and more recently has developed accelerated chest pain symptoms, not only with dyspnea as an ischemic equivalent, but also pain radiating to the interscapular space. And her primary cardiologist had performed an echocardiogram, hearing a systolic murmur, and the echocardiogram in January demonstrated what had been recognized as moderate mitral regurgitation now to severe, and with a mean aortic valve gradient that was preserved at 4 millimeters mercury and preserved ejection fraction. She was referred to our institution then for cardiac catheterization, and I performed a right and left heart cath. And just very briefly with regard to the right heart measurements, the mean wedge pressure was about 16, but with V waves that extended to 30 millimeters mercury. There was moderate pulmonary hypertension with a mean pulmonary artery pressure of 32. But also importantly, her cardiac output by FIC was significantly reduced to about 3 liters per minute, and the index accordingly was also less than 2. She's been clinically stable, however, and we performed a cardiac catheterization on the next image that showed her coronary angiography. And specifically, you can appreciate the angiographic appearance of the coronaries are normal with the exception of the ostial left main. And again, this is a re-implanted coronary artery. You can see a bit of the distortion of the aortic valve after the Bentall procedure too, of post-surgical changes. But the coronary anatomy shows no significant disease other than the ostium. Expectedly, there was severe pressure dampening upon catheter engagement. And then the other complexity is hinted at also in this same image. If you appreciate the right coronary ostial stent, it extends, as we'll share with you in the next image, quite substantially into the aorta. And in fact, from a femoral approach, multiple different catheters could not engage or cannulate the cylinder of the stent. The stent extends, you can see, at least 5-6 millimeters or more into the aorta, and then there appears to be a stent fracture in the mid-segment at this hinge point, and severe stenosis at this segment as well. So we paused at this point to review with our heart team, with Vino Thorani, Vivek Rajagopal, and Pradeep Yadav, about surgical options for mitral valve therapy as well as bypass. And she underwent a 4D valve CT that demonstrated very dense pericardium, a porcelain aorta, and because of this was not considered to be a suitable candidate for bypass surgery. She has, however, been reviewed for a clinical trial of a transeptal mitral valve replacement therapy and seems to be an excellent candidate for this, with the provision that she undergo complete revascularization. We can go to the next slide, please. So in summary, we have a patient with re-implanted ostial left main disease and re-implanted ostial right coronary artery disease, now with a complex in-stent restenosis with significant stent extension into the aorta and then perhaps stent fracture. And our procedural strategy was to perform ostial left main PCI with imaging guidance, and then really to leverage the expertise on this panel with regard to how to address the right coronary artery that we'll share with you in more detail. So again, accelerated chest pain and dyspnea, significant ostial coronary artery disease, both from the right and left systems, opportunity for transeptal mitral valve replacement, but needing, of course, complete revascularization as a prerequisite. I'll stop there.
Wow. Thank you for showing us this simple, straightforward case, Dave. So I'm curious what the panel thinks. It seems like the left main should be pretty straightforward, right? And the real dramatic issues, Prashant's nodding his head, is what to do with the right coronary. So I'm curious, just very quickly, Conrad, we'll begin with you at the end. Sunil, you're up next.
Yeah, getting into it is the first challenge, right? Yeah, and in these cases, we spend a lot of time with getting access from afar, our R4 guide, and trying to get a wire in, potentially a guide liner in to help guide us into the vessel, and that's really the gist of it. Finding the right guide. It's challenging. The challenge also becomes manipulation of the catheter and the root. You can make things worse by further deforming the stent.
Yeah, Dave may or not remember this, but when I was a fellow working with him, we had a similar case of a protruding stent from the right coronary, and these are very challenging. And I think the strategy that we ended up having to use in that case was actually going through the stent. Right. And basically crushing that part of the stent that was protruding in the aorta. It's not, what you'd like to do, but sometimes you have to. And, luckily that patient did okay, but this is a very, there are complicated cases, technically complicated cases clinically, and this is clearly one that's both.
Tell us what your thoughts are, guys.
So we elected first to proceed with the left main, just as you suggested, Dave. And let me just, I'm going to ask Prashant just to take us through this, or to narrate as I move through the images. But just as Sunil describes too, our options are to perhaps go through the side cell struts. And I did a little investigation and was able to find the brand of the stent, because the strut cell size vary according to both the diameter of the stent and the brand. This is one that perhaps would enable us to get a cell size of up to 6 millimeters or more in diameter, or we've tried before to fracture the cell struts simply to increase the cell size in cases like this. The other opportunity would be for us that if we could confirm direct entry into the cylinder and then revascularize in that method with another stent, and then perhaps we could use something like an ostial flash to try to trumpet the origin that's so extending out as well. So let us first take you to where we've been this morning so far here with regard to the left main, and Prashant, perhaps you can narrate as I move forward.
So good to see you all on the panel, Dave, Sunil, and others, Mirvat. So again, remember, these are re-implanted coronaries following a Bentall procedure. So this is so we elected to go via the right radial approach. Remember that the last case was femoral. This is a right radial approach. We have a 6/7 slender sheath in the right wrist. with a 6 French XB30 guide. We have 2 workhorse wires in the LAD and the circumflex, mainly just for additional support as we pull the guide out. And you can see there the ostial lesion. We then IVUS this, and we can maybe go down to the IVUS image, Michael, if we can show that.
Perfect.
So you can see that it's sort of dense fibrotic. The minimal luminal area is 4.9 millimeters squared. In a vessel size that's approaching 5 to 5.5 millimeters, with effectively an 80% stenosis. So we then direct stented this. This is a 5012 drug-coated stent that we're placing here, and we deployed initially to nominal.
And just to make a quick comment on this from a technique perspective, this is an instance where many might say, well, why do you use 2 wires? Because it's really just shaft ostial disease. But by having 2 wires, it serves as a rail to pivot or leverage the guiding catheter off the ostium, because when we engage directly without a wire, we had expectedly severe pressure dampening associated with it. And so this enables us to kind of work off one wire but leverage the other as a rail for the guiding catheter to move back and forth.
And then initially we rechecked her left ventricular end diastolic pressure, which was around 17. And in the setting of her normal LV function, we did not feel hemodynamic support was required here. So you can see here our final result following high pressure post-dilation. And we confirmed that with IVUS and had a nice expansion and apposition without any evidence of dissection with final IVUS and angiography.
Okay. So here we are now to the next step, and we'll come to fluoro here as well. And Prashant and I gave a lot of discussion pre-procedurally about this with regard to our selection of guide catheter. It's quite a vertical downward taking stent that's extending more vertically up into the aorta. And to try to engage it, we've elected to start with an AL 0.75 guiding catheter. This is a 7 French guiding catheter, and we initially have been thinking that perhaps if we need to take the back end of the wire and advance it near the end of the catheter just to get better manipulation, or even truly leverage the angle of the catheter to focus it more towards the cylinder. Our goal is to try to wire through the cylinder of this if we can, rather than crushing down that component of the stent like Sunil described earlier, which is option B. And sometimes we'll put the wire and leave it in just for that purpose, the 035 wire. But I don't think, well, we'll see. Let's take a look here and see where we can, if we can wire right to the, or if I can manipulate this catheter right to the origin here. Can you puff that, please?
Ravad, Sarah, this is live, and David will probably make this look easy, knowing David. But I wonder if either would use a diagnostic catheter and then just wire it that way, and then bring your guide in over that wire. I'm curious. Has that worked for you in the past or not worked, Sarah?
Well, you know, so a diagnostic catheter is one strategy. Also,
that looks better.
If you want to try and get in the middle of the stent, sometimes what can work is a baby J, and see if that can make it within the lumen of the stent. But my feeling is that if you have to crush the stent, this is a neo-aortic root, and it's not exactly the tissue. So I think if you have to go through the cells, as long as you get into the main body of the vessel, I think
just get this catheter
crushing the stent might be a good strategy, because this is not the normal route. Looks like
Try it
there. What would your approach be?
Sometimes a multi-purpose for a straight takeoff vessel would kind of help align, and I would try to redirect it from above. The only thing is this is not a normal case, so radiation and re-implanted coronaries, both ostial disease, I think the selection of a stent is critical here, something with a very good radial force, and not just the diameter is important.
Yeah, I'm sure we're going to be able to talk about that once we get to the point. Rhian, I'm just curious. I give David and Prashant so much credit for showing this live wire, But these are the ones I think you just have to make sure
Just
that
wants
you're
to
going to
keep going.
persist, right? And do you have any tips or tricks that would help us in the audience?
I think remote wiring for this is probably going to be your easiest, but I think using a multi can certainly help too. But the AL catheter, once you get in there, I think is
can
going
see
to
'em
give
on
you
the
the best seat. But these are just always challenging, and
There
you
he
wish.
goes. Nice.
There we
job.
go. Great
Well,
job.
we're-
I knew if I just kept talking, David would get it.
No, you know, this is like
close friends.
in the spirit of basketball, this is still, from the bleachers, right, with no backboard kind of thing. It was whoever was mentioning, was it Mirvat or others, remote wiring. But the other issue now is to confirm that we're really within the cylinder here. So what we're going to do is Prashant's going to just walk this back. I'm going to walk this
We're
back.
just going to use a trap, a balloon to, this is a short wire we're doing this on. It's a short workhorse wire. And we're going to just trap the, this was a Turnpike LP support catheter that we're now going to just take out after we've trapped the wire in the guide. And really, I mean, so all of the discussion is actually spot on. I mean, these are all the things that we were thinking about, but we need to confirm where we are. Are we through and through? Are we through a strut?
And that 16.
That will dictate what our next step is. And so we really, I can't emphasize, I'm going to pull this, can't emphasize enough how important intravascular imaging is here to confirm that.
Thank you.
Trap down.
Now, I'm going to take the trapper out, and we always make sure that we really bleed back here and we didn't entrain any air. We're going to go with imaging just as Prashant mentioned first. But let me ask you, and I'm asking Prashant too here, doing this hand in hand, is do we need to think about, should we think about a trap liner here? Are we going to need that for anything? Probably not. I think.
Yeah, I think this IVUS sort of run will tell us a number of things. Not only if it crosses, but also sort of depending on if we're through a strut and so on. So this will give us a lot of feedback and information. So let's see how this goes, and I think we can answer that question, Dave, once we see how this behaves.
Yeah, I think it's going to be amazing.
So this is going to be telling here for us.
There we go.
There it goes.
Now I heard somebody say, "Oh, I hadn't even looked yet." You can see that there's a struggle past that point that I feel is likely a fracture too.
Yeah. So it caught. If you notice carefully that the IVUS, it's gone through. That's very reassuring because this suggests to us that the delivering equipment subsequently is not going to be a big issue. But it did catch there for a moment. So either that's an open cell or it's some calcium or some other spicule that we need to be careful about.
So let's go ahead.
Tell the audience why you thought there was a stent fracture there. Is it just angiographically you looked at it?
Yeah, it was my suspicion is based purely on angiography. You'll recall that in the setup image we shared with you from the diagnostic cath, there's a point of inflection there, and there seems to be significant distortion at that site as well. And expectedly, as we know with stent fracture, it's at the site of the most severe restenosis as well. So we're going to hit record here, and I'm going to do a pullback. And you can appreciate here the reference vessel diameter. There's a little bit of eccentric plaquing here. The reference vessel diameter is about, about 4.0, 3.5 to 4.0. And we're going to come into the cylinder of the stent here. So just as an aside, tactile sense, there's a lot of tension here as I'm pulling back. So you may inadvertently see a jump. Yep.
There. But still reassuringly within the true lumen of the stent, so that's very good.
Little bit of under expansion, right, Prashant?
For sure, yeah.
All right, and then I'm going to pull the guide back a little bit more here.
And now we're coming to the real sort of important area, which is the real ostium of the stent. And so it's possible we went into, and there you wonder, go in a little bit more, Dave.
I don't want to lose everything.
Yeah, it's possible we may be through a side strut there. Let's confirm that.
So that's in the cylinder.
Yeah, there.
And then here.
There we may be just outside.
Guys, I'd say we're out there. Don't you agree?
Yeah, I think so.
Yeah.
There, we're just out.
Yeah.
Okay.
So I think here we have a couple of options. Either you can use IVUS as a guide and take a second wire.
Take the pilot. Yeah.
Pilot
Sorry,
200.
keep going. Prashant.
So we can take the two options that we have here, guys, is that we can either make an attempt to wire the true lumen of the stent with IVUS guidance. So as you can see, Dave's left the IVUS catheter in there, and with IVUS we can try to wire the true cylinder of the stent. And that would be ideal, in which case we're not sort of crushing the side struts of the stent. But failing that, we would then just take this and just crush the cell open. But we'll give it a go here. I mean, it's not unreasonable to try, I think. And really, parking the IVUS in there will really kind of give us a guide in terms of where we are. Need to push back on that.
Yeah.
Okay, that's good.
Okay.
So I like that baby J idea. You know, that if I was trying to wire this, I think I'd do the same thing with some kind of wire. You know, put an exaggerated J and just see if it'll pop on through. But honestly, I thought they were through it essentially, and so.
Which I think highlights the importance of imaging. Actually, we would never have known that unless we had looked.
Yeah. No, I think it's an excellent point, and also knowing what you're seeing, right? Do you guys have any sense? Is the stent appropriately sized and you just got aggressive ISR? Or
I think it's reasonably sized. I don't think it's far off. Remember that, you know, the ostium of vessels has a higher incidence of restenosis to begin with, partly because of fibrotic change, calcification, and certainly recoil. And then on top of that, you add on the fact that these are re-implanted following a Bentall procedure. So really a high-risk sort of location for restenosis.
So I'm gonna just pull the IVUS catheter back to that image, trying to get it to where. There we go. You can. I'm trying to get it to sit right there. You can see us. And the question is, can I get it into the? Now do you guys agree? Is that look?
It looks like it's in there. It may be in there.
good start.
I mean, can you see our IVUS though? I think our wire is in the cylinder. You see the IVUS is right at the origin where we're out.
If you pull the IVUS back, you make.
Let me try. Yeah, let me try. If you focus on our IVUS still with us. Okay, I'm in the catheter. I'm going to go forward.
Okay, back again.
And now we're in the cylinder, but I'm going to come back. And I think right at 6 o'clock, or I should say noon above the catheter, I think our wire, this is a Pilot 200, and I think that's in the cylinder.
Yeah, it looks like it.
So we may get some feedback if we advance a turnpike too.
Yeah,
see how that behaves.
Right, exactly.
My next step here, so bear with me.
So you may see something on the IVUS here as the turnpike comes through. We're going to keep an eye on that.
Well, it goes quite smoothly through there. Why don't we do this too, Prashant? Let me get this other wire back. Don't like that.
I got you.
Why don't we exchange this out for let's say a run-through wire, another workhorse wire, and then we'll come down on IVUS on this wire and re-image to confirm. Does that make sense to you all?
Yeah.
Sunil, this goes to your earlier thought. This is a 7 French guide, right? So if we're going to use IVUS and try and put wires to guide it, 6 French probably is not going to.
That looks good.
Yeah, I think that's right. In the previous case, they had 3 wires down, plus IVUS, plus a microcatheter. So you needed something larger like an 8 French. Here you've got 2 wires, IVUS, and a microcatheter. So 7 seems reasonable.
I can also take our IVUS out at this point.
Yep.
All right, tell us what you guys are thinking now.
So we're just about to, Dave, we're just about to exchange. We've taken the Pilot 200 out. We're going to exchange for a workhorse wire and then do a final sort of confirmation to make sure that we think we're through the strut. We just need to confirm that.
The IVUS.
Yeah, IVUS catheter on the new run through to see if you can.
That's right.
If you're
Exactly.
inside the barrel.
Correct.
Okay.
We
You'd
think
probably be able to tell from a tactile point of view too.
Yeah,
You may
well,
not-
so
you don't feel a lot
the
of-
tactile feedback was promising. As the turnpike went through, there was not any kind of interaction or resistance that you might expect if we were through a strut, but it's difficult to tell in this situation. So we'll take the trap balloon back, please.
Yeah, I just need
Prashant, tell the
to
audience why it's important to
need to
change
get this
out the
IVUS
pilot
out.
wire.
Yeah, so the Pilot 200 is sort of relatively more aggressive, and especially if you're doing maneuvers where delivery may be difficult, the wire can move back and forth distally, and the risk of distal wire perforation is much higher. So it's always best practice to exchange out for a workhorse wire once you're through with your Pilot 200.
just gonna.
Have you guys thought ahead a little bit about, I mean, it's unfortunate, but it's likely this patient may come back for more work on this particular vessel in the future.
Mm-hmm.
You're through the barrel now. You probably will go ahead and stent through there. Is there anything you would do with the stent still, hanging out in the aorta to prepare potentially for the next time?
Yeah, that's a great question. I was actually wondering that myself. What he's really asking is, would you snare it?
Well, I think our first sort of thought was to really try and trumpet the ostium here, right, and use an ostial flash balloon. And that, I think, gives you your best chance of kind of reducing any issues if you were to re-engage in the future. I think it's going to depend on how this ends up and what kind of result we get. But that, I don't think snaring it or taking it out is going to really help.
I'm just going to take out this wire as well. I don't think we need it. We know it was outside the cylinder.
Yeah.
Yeah. So, because I'm just getting a lot of resistance on the system here.
Okay, great, thank you.
Okay.
So,
and then let me just bleed back, and then I'll take this back, and then we'll do the trapper.
Guys, Houston once again was able to get an extra 5 minutes on your transmission.
Appreciate it, Dave.
Thank you.
Appreciate it.
We're at 12 minutes now, okay?
Thank you.
So,
call me flight.
A
Trapper
great
balloon.
question that we got from the audience was asking, how many millimeters do you think is acceptable for the stent struts to be out in either the left main or the RCA?
Well, that's
Go up to 16,
that's a
please.
great question. So how much is too much and how much is too?
Well, I'll give you my answer, and then we'll see what Dave says. I mean, obviously, the least amount possible, while still
Hold on.
while still covering the
Come down.
while still covering the ostium. But the ideal scenario would be maybe a couple of millimeters, 2-3 millimeters at the most, especially if you're planning to use the ostial flash afterwards. Dave, what do you think?
Try to go 16 there. I would say that's really, first of all, where the benefit of imaging comes in, because, sorry, I just got a little tenuous situation here, so I want to make sure that we didn't lose the wire here. But it's really, I think that's where co-registration with imaging is really advantageous. And I'll tell you, if we have a moment, we could go back to the left main, but, with this Bentall especially, there's a roof to the left main, as there commonly is, and then there's the underside of the left main, which typically is hanging free in the aorta. And I think you have to bring the stent out to cover the plaque on the superior side of the left main as well. So the left main to me is even more challenging than the right sometimes in terms of how much stent should be extending out. But it goes without saying, as little as possible, but still covering the entire structure of the disease segment too. So let's see here. We can go back, Michael, back to IVUS Live, and
So here's the moment of truth. This will be a telling kind of run here.
Music is playing.
Yeah.
Okay, that's promising.
Okay.
Okay, so record.
Yeah.
Okay, so recording. Here's our run where we think we're through. So again, here's the stents distally.
See, I think that catch area, I think that's the area of what I perceive as the fracture. Yeah.
Sure.
Okay.
And Dave, to your earlier point, it was the dry cine run that we had earlier that made it look like a stent fracture fairly obviously, but so far promising. What about that very origin there?
Yeah, it kind of looks similar to the previous run.
Yeah.
It sure does, doesn't it?
Yeah. hard to say, guys. It really is.
Possibly,
right there.
maybe just one strut. I would favor then in that
I'd say
case
we
just
move
to move
forward.
yeah.
Yeah.
So I think given that the IVUS will take the 3020 balloon. Given that the IVUS has gone, we feel comfortable that we're going to be able to get a balloon in. So I think we'll just take we've got a 30 balloon lined up. We'll see how that crosses and hopefully go up on that.
You know, it's funny, Don Bain used to always preach that we're not taking enough time to find the right angle for osteals, right? And it's always amazing to me, at least the times that I've had mine come back way too far. When I go back and look at the films, it's exactly that I didn't identify where the ostium was is the biggest issue.
Yeah, I mean, there are technologies obviously that are available, you know, Ostial Pro, et cetera. I mean, they're expensive, but they do seem to work.
You know, the other many people do too, Sunil, is just put a second wire out the guide and let it loop in the aorta and use that as a marker.
Wire.
I mean, the other technique that I think we all have heard about, and that goes pretty easily, so that's
Very easily.
That's good.
Yeah.
The other technique, obviously, is a Szabo technique where you take a distal stent strut and put a wire through it. But
12.
I've never had much luck with that. So
this go to 12.
So this is a 3020 regular semi-compliant balloon, and that looks like it's expanded adequately.
Yeah, I mean, again, if it is, it's one strut, but it doesn't look like if you look to the left and to the right of the inflated balloon, it doesn't look like we've distorted the cells. But again, it could just be one cell. Yeah. I'm gonna take advantage of that balloon catheter and just come in here. And let me just take a picture.
And that was a 3.0, right?
3020.
Okay, great. Thanks.
My pressure is obviously dampened because we're deep in it now.
Yeah.
Let me come out of there. I'd say, would you want to IVUS image it again, or do you want to?
We have the information we need. We know it's a 4.0 vessel. So I think the only
how
question.
How long of a stent are you going to put in?
Yeah, that's the.
I was going to put a 4026 stent in because there was a little bit more plaque extension distally. Can we get that 40 stent?
4026 stent. So Sunil, this is a 20 length, so I think just a little bit more than that, I think would be adequate.
That said, I think we're still going to have to do some aggressive post-dilatation there. You see that area of under-expansion of the balloon.
What's your thoughts about shockwave for ISR?
Yeah, my survey of the literature, and others can give me their different opinion, is that it's certainly effective, but maybe less effective than de novo calcific disease. I'd have to say that's been my anecdotal experience as well. Although, having done a lot of laser in the past, even with contrast for In-stent Restenosis, I'm not sure that it's anything less than that method too. So if we get into a situation where we have to go with shockwave, we have it here too, and it wouldn't be the first time for me that I've put the stent in and then had to come back with shockwave as well.
Right. And then you're going to cover
that's
ostium,
delivering
right?
very well.
Yeah,
yes, we're going to cover the ostium for sure.
I mean, so even though it was
It's that
way
same
out
catch.
there,
Yeah.
we got to cover it way out there. There's no way getting around that. It was going well.
I said it was.
Yeah. That's.
You think that's the area that's fractured?
Yeah, it could be. I think it feels that way. I think the next step here would be potentially to take a guide extension and just take out that interaction between the old stent if we needed to.
So I was going to ask you, Prashant, is it a guide extension or just a second buddy wire that seems to help better here?
We could. I mean, the problem with getting a second buddy down is that you're now dealing with an old stent and struts that we've already had some issues with and a fracture, and so.
Absolutely. Yeah.
Okay, let's go ahead. Let's take a 40. A 4020 NC balloon, don't you agree?
Yeah, let's try that first.
CT overlay, which we've done in TAVRs, where you can have fusion imaging and CT overlay, and it'll show the ostia of the coronaries very nicely as well. It's not available everywhere, but it has a potential for these kind of cases to help.
Really appreciate it.
Dave, I think you wrote probably the best paper on stent fracture from the old Cypher days and the across Cypher experience.
Yeah.
It seems like it's more common in the right coronary. You think that's just because of the motion and the torsion on the vessel?
I do. You know, that's as an example with CT angiography. For those who do this, we know that the right coronary artery, because of its temporal resolution, is the most difficult. It has an excursion of 3 centimeters with every heartbeat, and there's so much more angulation and flexion points. And we discovered that with Cypher, thinking at the time that it only occurred with that stent because it was a thicker strut stent and it was more visible. And now, of course, we know it certainly occurs with other stent designs as well. But it was a story of you don't know what you have until you look for it. And it got discovered in one of our CTO trials, Sunil, as you know, the Across Cypher trial, because the core lab called up and said, hey, you know, you missed all these areas of stenting where they've re-stenosed. And we said, no, we didn't. And we went back, and sure enough, those were the areas of fracture.
Hey, guys, I got ACC was gracious to add another 5 minutes to your time. So you got a full 8
Terrific.
minutes,
Thank
15
you.
seconds.
Want to do that?
We're here for you.
I have a question.
Let's go up there to 12.
Sarah, go ahead.
Yeah, I know.
What would be your strategy on the dual antiplatelet therapy and then conversion to single antiplatelet
16,
therapy in this patient
20.
with ostial Bentall stents?
Oh, boy. That's a great
That looks
question.
better.
That's good, but yeah, much
What
better.
was yours?
And down.
I mean, dual antiplatelet therapy, then probably for, I guess, a year,
Try
and
the
then
stent again?
P2Y12
Yeah, we're already with
indefinitely.
Yeah,
Just
yeah.
kind of-
Not aspirin, definitely, right?
Probably not
P2Y12. Yeah.
P2Y12.
I think that would make some sense here.
So I shared your thought, and you can tell me if you disagree with this, but I started her on ticagrelor. She had actually taken it previously when she had her stent in 2017. She said, so she was familiar with it, she tolerated it well, and then, yeah, we could think about, and then she's got to get her mitral valve done too, but we could think about thereafter single antiplatelet therapy with, you could do with ticagrelor, right?
I think I would. Yeah.
Although, to be fair, that's not going to affect restenosis, right? I mean,
No.
That's the whole challenge. I wish we had the magic pill, right?
So the stent this time went fairly readily, but I didn't share with you guys, but I was a little bit worried last time because when I got the stent in and it wouldn't go forward, it also wouldn't come back. So I was saying, I was just thinking to myself, we're going to have a new challenge for us. Now, do we want to line up to where we are? Because I'm just going to dry Cindy here.
5 minutes.
I wonder whether we need to actually come proximal and cover the previous stent.
I agree.
I agree. A little bit. Yeah.
Come back a few. Yeah.
I'm just going to dry Cindy it here. I like that.
Yeah.
Want to do that?
You want to puff or just go up?
Just go up.
Yeah, let's go up there. So this was, just prior to this, we had taken, initially it was a 3.020, then we took a 4.020.
14.
And this is now a 4.026 stent. So it's always good to have a plan B. We were thinking about buddy wires, we were thinking about guide extension, but just simple, more aggressive predilation helped the cause here. And then we're going to maybe go up with this delivery balloon and just hit the ostium here. So
we'll also get that one segment that is still a little underexpanded.
So that's 16.
Okay. And you don't see, come on down. I have seen when I've gone across cell struts before, unless we just expanded them of the previous stent, but I have seen instances where you'll just have a complete constriction of the balloon because you're across you're within the struts.
So assuming everything looks good here, the next step would, after maybe we IVUS, we might consider the flash next. Potentially.
How's your guide pressure looking now, Dave? I mean, you're engaged pretty well now. Previously, it was pretty dampened.
Now my waveform is normalized. We've she got a bit bradycardic on that stent delivery, but
you want a picture?
Yeah, let's take a picture.
Nice.
Very nice. Very nice. Very nice.
Yeah. Now, in theory, in this view, we're still hanging out a bit, and I think there's still an opportunity for the ostial flash, but I think we'll do a little post-still first. But let's just take a moment to image for you all, just knowing we're a bit limited in time.
Okay. And it is amazing how healthy that vessel is distally.
Yeah.
I mean, the whole mid-right coronary has plaque in it as well. Tell us about your thoughts about radiation for ISR of 2 levels. Where do you guys go to it? What are your thoughts on it? Does it work?
Ooh, that's a loaded question. I've got image. I've got IVUS up, by the way, and I'll speak to your question, Dave, while I'm doing it. So I think we've got good stent. We've got no edge dissection there and good stent apposition so far throughout. We're, I've been kind of in a waiting period for drug-coated balloons to come about as an alternative solution for what really is still a palliative therapy that is.
And there it's hanging out a little, just minimal.
In-stent restenosis. But I don't see. I mean, this is within the vessel. This is within the vessel, right?
Great.
Yeah, and then
just right there,
still in the vessel there, just a strut, very minimal out in the aorta, I think, right?
Yeah, I'm not even sure. Do you think we need the osteal flash?
I'm not sure we do. I think.
Yeah, I don't think you need it.
1, 2.
Yeah,
three,
but
four.
we're also not compromised by any ring of a strut that we went through or anything like that of the initial stent. So Dave, we haven't embarked much on brachytherapy, just awaiting some other alternative and knowing the palliative nature of it. It clearly would be something for a last ditch effort, and throwing the kitchen sink when you've got 2 layers of stent and no other therapeutic alternative. But what I've been working with planning for clinical trials in the drug-coated balloon space for in-stent restenosis, and being sure to either stratify through randomization 2 stent cases or have as a single-arm registry the opportunity to treat 2 stent layers of in-stent restenosis at 2, recognizing that it's becoming increasingly more common. I think the 40NC again, please. So what what I think we'll do here is just go back. I think there was an area of under expansion, and we'll post-dilate this segment again. Like we discussed, I'm not certain that we need the osteal flash balloon, though.
I don't believe we do. This is the.
All right, guys, we're down to about 90 seconds here. I'm really.
So our strategy here is,
how well you've done.
No, thank you, Dave. We're just going to go back, post-dilate this segment, and then repeat our imaging just to ensure as optimal stent apposition as we can get. I think based on the images with IVUS that you saw, I think this can be resolved with post-dilatation with a non-compliant balloon. I don't think we need shockwave for this either. You agree, Prashant?
I think we're done.
And we'll repeat with imaging after this post-dilatation too. But we've gotten through a lot here, and we got through a lot with your all's guidance. So we're very grateful for all of your comments.
Well, great case. Thanks, guys. Excellent job.
Congratulations.
Thank you all.
Thank you very much.
Hey, thank you. All right, well, that was great. I want to thank the panel. I think I learned a lot. I hope everybody in the audience did as well. Okay, guys? Thank you.